Welcome back to Psychiatry Boot Camp. Today we are talking to Dr. Owen Scott Muir, who is an expert in a lot of things. He's the author of the Frontier Psychiatrist podcast, and he will give an extended introduction about the 100,000 different industry-related things that he is involved with. We're going to talk about transcranial magnetic stimulation, which is a little bit like magic to me, to be honest with you, and I'm sure to many of you, which makes this an interview that I tried to approach with a very beginner's mindset, because I have a very beginner's mindset. We talk about how TMS works, what TMS is indicated for. We talk a lot about the FDA approval process or clearance process for this technology. We talk about what the future might hold for TMS. As you will hear, Dr. Muir is a very high energy interview. He's a very fun person to listen to, and he says a lot of things where you feel like you want to ask a follow-up on that little thing, but you also know that then we would need another 10 hours, and so we may have to have him back. Enjoy this episode on transcranial magnetic stimulation. Dr. Owen Muir, welcome to Psychiatry Boot Camp, and I will ask you to introduce yourself to our audience.
I am Owen Scott Muir. I am a child, adolescent, and adult psychiatrist by training. I have those extra letters after my name because I'm a distinguished fellow of the American Academy of Child and Adolescent Psychiatry, which means I did a lot of extra work. But it's fair because I met my wife at the ACAP conference a decade ago now, maybe a little bit more. I work with kids, adults. I'm also the chief medical officer and co-founder of a company called Radial, which is a health technology and services company, aka we deliver care and build tech to make that better. I'm also fractionally the chief medical officer of a company called Neuraleaf, which is an Israeli neurotechnology company, which built two devices. One is called Relivion, an at-home treatment for migraine, and the other will be ProLive RX, and it's an at-home and in-clinic neurostimulator using combined trigeminal and occipital afferent nerve stimulation for major depressive disorder that hasn't responded to treatment with other oral medications. And I'm an advisor to a number of companies. I'll mention those that are regulated and thus disclosures. I'm an advisor to Siren, which creates vocal biomarkers. I've been a principal investigator there. I have a small amount of equity in Mind Medicine, where I've also been a principal investigator. They're a psychedelic drug development company. I have, I think, like 10 shares of Compass because I wanted to see it move around. And now Radial has a contract with them. They creating the Comp 360 asset. I am an advisor to a company called Videra and was a principal investigator in an NIH R44 funded grant for the development of AI identification of tardive dyskinesia, which is now in the world as a product called tdscreen.ai. And I have some equity in a company called IRX Reminder, which co-developed that software and builds medical devices for adherence to medications. And I'm probably forgetting something. Oh, now Purple Gaze, which does gaze tracking. I'm an advisor. That's a medical device, so it's also regulated. I I'm married to Carleen McMillan, who is an advisor to a company called Emobot, which does passive sensing, which is also a regulated medical device. And those are disclosable things that I can talk about.
Okay, thank you for getting ahead of us with those disclosures. I think and I knew this before you went through all that, I think you're involved in more things, generally speaking, than anyone I've ever met. One of the ways that the way we initially met was that you wrote some very kind words about Psychiatry Boot Camp in your Frontier Psychiatrists newsletter about a year and a half ago, and then reached out to me personally to offer mentorship. So it's been wonderful to have that mentorship from you. I really appreciate it. But today we are here to talk about TMS. So let's dive right in. I want to start with the history of TMS, right? So this is one of the leading tools in our rapidly expanding field. I think there's a lot of future ahead, and the future of psychiatry is the theme of our season. But let's start in the past. Could you walk us through how TMS, transcranial magnetic stimulation, was discovered and how its applications in the field of psychiatry have evolved over time?
I'll start with how I discovered it. I was a psychiatry resident at the Hofstra Northwell program at the Zucker Hillside Hospital. And in my third year of psychiatric residency training, I got cripplingly depressed. I have bipolar disorder. And I remembered when I was in my 20s, I was a research subject for J. John Mann, among others, who gave me a lumbar puncture in a study he was doing with Maria Okendo around suicidality and bipolar disorder. And one of the other folks I stayed on the schizophrenia unit because they ran out of beds in the research unit, which is actually where I kind of got the idea to go become a psychiatrist. And one of my other study participants on the schizophrenia research unit told me, well, I'm getting TMS. I'm like, what's that at age 20? Fast forward many years later, it had been approved in major depressive disorder, but it was not a mainstream treatment. I've got bipolar disorder, which for at the time, and still it's not indicated for. And I went and saw my doctor, who I've been seeing since I was 20. Maria Okendo referred me to him. And Mike Dulchin said, look, I don't do TMS, but if it works, it's easy to recreate. And I know this guy across town, Robert McMullen, who does TMS. I think you'd like him. He's kind of kooky. And I think you'd get along. And I was just like, whatever you say, Mike. I'm like the most compliant patient on earth. When I roll up into my doctor's office, I just do whatever they say, no matter what the discipline, basically. And so I went and saw Dr. McMullen, and he did an evaluation. And he said, let's try it. After my first treatment, and this was in the spring of 2015. Walked out and had the first full meal I'd had in months. Most TMS clinics are open 5 days a week, and we'll get back to that because it's important as a number. He had 2 different offices. So he had one in New York City, which was open 5 days a week, and one in Mount Kisco, New York, about an hour and a half north. It was open on the weekends. So I got my 5 days of treatment in the city, and then my now wife came to visit me, and on Saturday I was fine, and on Sunday I powered down like a robot. And she's like, what is happening? Your depression is back. Oh my God, let's drive you to Mount Kisco. I walked in like a zombie with psychomotor retardation. That's what we call it when you're walking slow and moving slow and thinking and talking slowly. And I got a treatment with transcranial magnetic stimulation, and I walked out like a normal person. And my wife, who's also a psychiatrist, Carleen McMillan, who works at the same company I do now, Radial, said, what happened? This is... we were both like, I don't know what to tell you, but I want to have brunch. It was revelatory. And now, obviously, not everyone has the same experience. I've later learned, and the research shows that some individuals with bipolar depression actually get better faster than the traditional unipolar depression. And TMS was the treatment for me. And I was able to get in the 7 days of time I had left before I couldn't complete training on time. I was well enough to go back to work, and I got the rest of the treatment in the evenings. And after that first course of TMS, I graduated on time, was able to start fellowship on time, and went. But I wasn't sold yet. Like, I'm going to be a child psychiatrist. There's no data for this in kids. What does it even matter? So that was my introduction to it. Now we'll rewind to the invention of TMS. So in the 1980s, Ted Barker in the UK was doing physiology research. And there are a number of other neurophysiologists who were doing work at that time. And he realized that a magnetic field could induce an electrical field. And he designed a figure of 8 coil. There are others involved, of course. No one's doing this in a vacuum, but Rothwell and others were stimulating the brain. And he figured out that this magnetic coil could make the motor cortex fire. And so you can find the thumb, which is the biggest part of the homunculus on the motor cortex, and you stimulate it, magnetic field. So here's physics class: thumb in the direction of the wire, fingers curl in the direction of the magnetic field, current induced in the wire. And so the axons in our brains are insulated with myelin. They are functionally wires as far as a changing magnetic field is concerned. So you induce magnetic field, axons will fire, and you can elicit a movement in the body. And this was crucial for the development of TMS because there are a bunch of ways to modulate the brain that are hard to measure. When we do psychotherapy, we're making neurons fire, but we're not watching your thumb move. So it's not as good of a motor probe. I guess you can yell, boot, and someone will jump. And that's a little bit of or you can measure startle response that way. But the ability to measure was crucial. So that was our motor probe version of TMS. And there are some of us who are a bit more iconoclastic, and one of them is Dr. Mark George, who I've had the pleasure of working with. Actually, I mentioned in the beginning, that company, Neuraleaf, which makes the ProLive device. Mark George was an investigator on that study as well. So he and I were just together at the FDA recently. So Mark gets the sense that this physiology probe might be able to do other things, because by that time they'd figured if you give a TMS pulse and you do it repeatedly, not transcranial magnetic stimulation, but repetitive transcranial magnetic stimulation, you could create an upregulation of neurons firing that would be durable. You could create long-term potentiation. And he moved that figure of 8 coil a number of centimeters forward. There have been debates over the years about exactly how many centimeters, and we'll get to that. But essentially, the left front of the brain, left dorsolateral prefrontal cortex, if you stimulated that with a pattern, 10 hertz, pause, 20 seconds, 10 hertz for 2 seconds. So that's called a train. It's a bunch of pulses in a row at a certain pattern. Intercession interval, and then another train. You would get increased motor firing over time, long-term potentiation. And just like you're using flashcards, right? You see a flashcard once, you'll forget it. You see it again, you might remember it. You see it 50 times, you'll remember it pretty well. And so by doing this stimulation for 45 minutes at the time, which is about how long you could hold up the coil, and also there was no cooling systems yet, so you had to duck it in a bunk of ice water because it got hot if you didn't have a cooling system at the time. But it turns out when that was eventually studied in an FDA clearance trial in 2008 with Neuronetics, the company as the study sponsor, it worked. Worked for depression, for major depressive disorder in individuals who hadn't been helped by prior treatments. Now, there are a couple of original sins in the development of TMS. And one of them was that we already had this motor probe around, and the FDA had already said it was safe to measure human brains with this motor probe. So we had an initial de novo, that's a brand new thing, approval for the motor probe. So we had the option as a field, and Neuronetics had the option as the study sponsor, of having this treatment for depression be regulated as an FDA clearance, not an FDA approval. And those are different words, and we can get into it more later. Or now, if you want.
Yeah, clarify that for me.
Sure. So the FDA regulates drugs and devices. It's actually different sides of the house, as it were. There are different buildings, literally, at FDA for this. There is the Center for Devices and Radiologic Health, CDRH, and there is drugs. Every drug is considered a class 3 risk, right? So you have to study those in replicated randomized controlled trials historically, that may be changing, to get an FDA approval. And an FDA approval means this is safe and effective. With medical devices, they recognized early on that if we've proven something is safe once, making someone prove it all over again doesn't make a ton of sense. And so safe and effective, well, safe may have already been demonstrated by another indication for the same device. And so for TMS, we already knew that this motor probe was safe to use on people.
So you just needed the clearance. You didn't need the full approval.
Just need the clearance.
Got it.
And that's great if you're doing that sometimes, but it also means anybody else can use that clearance to use your data to establish the safety of their thing. And Ted, who invented this, did not patent the coil.
Got it.
And so we had an unpatented coil that anyone could make their own version of.
And use.
And that makes it really hard to get a defensible product in the market and protect your intellectual property.
And continue development and research.
Right, because it's expensive to do that. And so, ironically, we invented this tremendously powerful technology with trillions of different ways to stimulate the brain. The parameter space is around 7 trillion when you combine the number of targets, the number of possible patterns for stimulation, the powers at which we could do it, etc. But very little return to any investor for putting the money in to do that. And so that's one of the things that helped slow down TMS progress. In 2012, the company BrainsWay licensed technology owned by the National Institutes of Health, because that's where it was developed in the US, and on what we call H coils, which are arrays of magnetic coils that add up to a magnetic field that can stimulate a brain circuit. In 2020, I believe we had the H7 coil. So the H1 for depression is actually bilateral. It's 12 coils on the left and 6 on the right. Basically no field strength in the middle. That was the first one. The second one was the H7 coil, which is 12 coils on the left and 12 on the right. You look like Princess Leia when you take off the covering. But it creates a stimulation right down the middle, so we can target the anti-correlated region with the dorsal anterior cingulate and treat OCD. Subsequent to that, we have anxious depression clearances rather. We have accelerated TMS with Saint, which is a combination product of fMRI guidance and AI algorithm to target the right spot in the brain to get around that tape measure problem, and doing it 10 times a day with a pattern called intermittent theta burst stimulation, which Jonathan Downer at the University of Toronto demonstrated was non-inferior to 10 hertz stimulation in a study, but it's only 3 minutes. And just in the past year, we've had the AMPA device, a company Jonathan Downer created, which has like a camera in the middle of it for ease of targeting, to which I'm also an advisor. That's a disclosure. And I've been a principal investigator with BrainSway. That's another disclosure. These series of technologies, and there are a bunch of other manufacturers, but a bunch of people built a bunch of TMS machines, stimulated a bunch of brains, got a bunch of people well from depression, now OCD, smoking cessation. We now have studies in tons, right? It's hard to keep up at this point in time, but we have approvals down to age 15, up to age 86. It is a burgeoning field.
Approvals, not just clearances, but approvals?
So these are all clearances because the original thing was a clearance.
Gotcha. Okay.
The only thing that is approved that I mentioned is that ProLive RX device, which is went through a de novo and breakthrough approval process as a first-in-class therapeutic, similar to the Flow device, which also got approved just a couple weeks ago.
So I'm so excited about this episode because I am genuinely confused about TMS. Like I
feel like
I learned about it a little bit in residency, and I vaguely, I've had patients ask about it, and I've seen people get better from it, and I've read a lot of your stuff. You do an enormous amount of writing, and especially about TMS. And I hated calculus. I hated physics with calculus, so it's not surprising to me that I didn't like. I'm more of a kind of a mushy-gushy kind of guy, but I didn't realize that it was not only scientifically complex, but all of this regulatory stuff is super important when thinking about what it's approved for, which, by the way, is what the ABPN tests us on our board exam, is like, is it FDA approved for this? So I feel like I've now learned that it's not just that I hate physics, it's also that there's all this regulatory BS. I shouldn't say BS because it's important stuff that physicians don't like to think about and that we don't teach about really in residency when we're practicing clinical medicine. So I feel a little bit better with how confused I am. I'm really excited about this next question. So when we met for our brief mentorship meeting, you said something very nice to me. Well, first of all, you called me a baller in the article that you wrote about Psychiatry Boot Camp for starting the podcast in residency, and you noted that you started your own project, the Frontier Psychiatrist. Would it be in residency?
The beginning of that, yeah,
the precursor to, and I rarely get called a baller. In fact, I don't know that it's ever happened to me. So that was really nice. But the second nice thing you said to me was, you do a really good job of getting really smart people and asking really stupid questions. And I was like, that's exactly what I do. That's what Psychiatry Boot Camp is all about. And I think that's what most good interviews are all about. So here's the question. Explain to me, like I am 5 years old, how TMS works.
So the youngest I've treated is 7. I'll quote a 10-year-old when I say what he told me, which is, "Thanks for deleting my anxiety, dude."
Wow.
What does it do? It is a way to learn a lesson, which is how to be less depressed or how to be less anxious. Except instead of reading a book or listening to a story or having someone tell you, you can close your eyes and let it go straight into your brain. Whenever you hear someone tell a story, you're forming a memory of what they said. And it might not be perfect, but if they tell you the story once, you'll remember it. If they tell you the story every night when you go to bed, you'll remember it forever. TMS, depending on where it's pointed in the brain, is telling your brain the story of how to feel better. And it's doing that with all the same mechanisms we have for learning. So if you can learn a story, you can learn how to feel better because your brain knows how to learn. I have a better metaphor for this, which requires being slightly older than 5.
Okay, I'll take the bait. How old do I have to be for the second metaphor?
Did you take a music class?
I would, in fact, yes, I'm a musician. Yes,
Me too. What did you play?
percussion. I'm a drummer.
You're a drummer. Okay. So if you have a set of drums that are out of tune, no matter how well you play in time, is it going to sound good?
Yeah, drums are probably the worst, the worst thing for this analogy. But no, it will not sound nearly as good as if they were tuned.
And imagine you got to play drums, but in your ears is a metronome that's at the wrong tempo for the song.
That's not going to work.
Not going to work, right? You're out of time with the rest of the world. And so what is depression? It's being out of sync with yourself and being out of sync with the rest of the world. And when I say out of sync, I actually mean that literally. Like your neurons are firing in a pattern that's not mirroring what other people are getting in their brains.
Could the same be said for any mental disorder, though?
Yes.
Okay.
And we'll get to it because it's not just mental disorders, it's all the brain circuit disorders, which include movement disorders and other neuropsychiatric illness. So if you imagine that when someone says we're on the same wavelength, they mean it literally. We have, the popular version of this is mirror neurons. But look, practice the piano all day long. If it's out of tune, it'll sound like crap. But your piano is not going to sound good if you're not in time, you're not in tune, and you're not playing with the rest of the band. So what is TMS? It's a way to tune the piano so that when you practice, it'll actually give you the feedback that sounds good. So you can learn how to interact with yourself. You can learn how to interact with other people because you're now finally in tune. And once you're in tune and able to get in time, you can get in the groove of your life. And so if you imagine there's something fundamentally off about your practice schedule and it's like they handed you, brushes when it's a rock song, and the metronome there's some latency there, right? There are all these things that can go wrong that can keep you out of sync. And depression is being out of sync. People will tell you, dude, you look off. And we don't necessarily have the language to describe what's off. But if you were looking at both people are in a fMRI at the time, maybe fMRI EEG, and we're looking at how those brain areas sync up, or we look at heart-brain coupling or whatever it happens to be physiology-wise. When we connect with each other, our brains perform processes so that we're creating mental representations that have physical encoding in neural firing. And our brains will fire in ways that are aligned. So when you're really getting someone, what that means is your brains are firing in a way that is aligned. And when you're out of sync with yourself or with somebody else, you're not firing in the same circuits in the same way to represent each other accurately.
I feel like a lot of what you're saying is what we describe as a field of interventional psychiatry, or maybe you could call it neuromodulation.
Yeah, but it's actually all of psychiatry. Like what therapy is neuromodulation.
Yeah.
A walk.
Yeah, it just feels more direct and immediate, right? You're doing it right now as opposed to a top-down approach where you're learning this. Yeah, I mean, I think it's more direct. Can we agree on that?
I mean, it's more directly targeted to the brain.
Yeah.
But it does help me understand why those other things might have been so potent.
Yeah, for sure. So can you tease apart for me at a high school reading level the differences between TMS and other neuromodulation therapies or therapies in interventional psychiatry like electroconvulsive therapy, ECT, or deep brain stimulation, DBS?
So transcranial magnetic stimulation, TMS, doesn't cut your head open and you don't go under anesthesia. It's non-invasive. It might sting a little at first, but most people don't actually consider it painful.
I mean, to be clear, ECT doesn't cut your head open, right?
Not yet, but you do go under anesthesia.
For sure.
And you do have a seizure.
For sure.
The risk profile is different.
Very.
I mean, it's also an awesome treatment for severe depression, and all psychiatrists everywhere should rah. But it's hard to access just practically because people don't want it. It takes 2 people to deliver ECT. You need anesthesiology, probably a phlebotomist as well, unless the anesthesiologist is really good at it or has the time. And you need a psychiatrist. For transcranial magnetic stimulation, you just need one other human to deliver it to you.
and you're awake, and it's a much more, you would say, targeted and well-tolerated intervention with significantly fewer side effects. Is that kind of fair to say?
That's fair. TMS sucks the least.
Although in terms of tolerability, in terms of efficacy, we are in agreement that ECT is highly effective pretty much across the spectrum.
No, ECT is effective in major depressive disorder.
Mania,
Psychosis, epilepsy, another non-psychiatric indication.
I see, but maybe not OCD, and we're not getting
OCD.
into the neuromuscular disorders, et cetera.
Correct.
Or I should say movement disorders, et cetera.
And so we also have data on SAINT treatment and fMRI-guided treatment that in ECT failures, we can get patients to remission with fMRI-guided accelerated transcranial magnetic stimulation. So there's a dose and targeting question. ECT is definitionally broad. We put you under anesthesia so you don't shake, but we induce a seizure with electrical stimulation. Historically, we did that with insulin shock. In Europe, we use magnetic seizure therapy, which is TMS turned up too high.
Really?
Yeah. So inducing a seizure reliably resets the brain in some way, but it's not focal and we can't choose meaningfully.
Right. You place the electrode somewhere, but you are by definition inducing a generalized seizure.
Correct.
Okay.
If you could only turn up or turn down the firing of a brain circuit, well, that would be starting with transcranial magnetic stimulation. And if you have a functional neurosurgeon handy, you can implant an electrode deep into the brain, which is FDA approved in Parkinson's disease and has yet more regulatory status, FDA humanitarian device exemption, which means you can do it not in a study, but still not approved in dystonia and essential tremor, same lead we're using in Parkinson's disease, or OCD with the same humanitarian device exemption. But if you want to do it for depression, it's either off-label or it's in a study, and overwhelmingly it's in a clinical trial.
Fascinating.
And so what you're doing with deep brain stimulation is generally you're disrupting a circuit in a reversible way. So we've historically had radio frequency ablation, aka gamma knife, where you can go in and lesion a tiny part of the brain such that a circuit is disrupted, or you can use DBS to use an electrical field to disrupt the circuit, but you can turn it off.
I'm so excited about this episode. I feel like you're really distilling down these high-level topics at a level that are going to be understandable, even for patients, but certainly for medical professionals. You've gone through a lot of this. I just want to see if I can get maybe a more clear list and state of evidence. Can you walk us through what TMS is currently being used for? So let's talk about, I think you mentioned there's maybe one FDA quote unquote approval. Well, there's one FDA approval, and then there's additional FDA clearances. What is the approval for? What are the clearances for?
So anytime you have a brand new device, and this is so long ago, I haven't even looked at this regulatory filing recently, so I don't want to overspeak, but there are 3 different classes of device approval. So there's only FDA approved for drugs, right, or not, but there's an FDA clearance hierarchy for drugs, or devices rather. So a class 1 device has very low risk, Band-Aids, tongue depressors, stethoscopes, medical use, but they're not going to hurt you. Class 2 devices are colloquially slightly more dangerous, but not that much. Right? These are not things that are going to impair your life or limb, especially if they go wrong. And class 3 devices are either dangerous in and of themselves, like extracorporeal membrane oxygenation, or if they are used in a life-threatening condition and go wrong, they could be risky, like depression can cause suicide in and of itself. And so you can regulate class 3 devices that have some risk in the disorder in which they're treating them. When you go through the good clinical practice training for running a clinical trial or participating in clinical research, they hammer this into your brain if you're doing drug and device training. So the regulatory status, how dangerous is the device? And if it's really dangerous, it's class 3, and that needs an approval. If it's not so dangerous, it's class 2, and that can either be an FDA clearance using the 510K pathway, where you're using a prior predicate device's approval as part of your submission. I'll give you an example. If I'm looking at EEG And using EEG to build a neuromodulation device, I can look at the risk profile of EEG. And EEG is a class 2 medical device. It's not particularly dangerous. Even below all of that, there's NSR, non-significant risk. It's just not going to hurt you. It's not more dangerous than walking down the street. And the FDA is not looking to spend a ton of time on regulating the risk profile of walking down the street, which it turns out has non-trivial risk. Like you could trip, you could fall. Like if you're talking on the phone, it increases that risk. Like it's not nothing, but it's just not what they spend their time on. But at the end of the day, the FDA is there to protect us from charlatans, hucksters, and over-enthusiastic healers, because before the FDA, drug companies would make a drug, send it to a doctor and say, hey, tell me what this does. That's how Adderall came out, right? When Adderall first came out, there was no FDA. So they'd send stimulants to doctors and tell us what this does for your patients. And they did. That was it.
Pretty clear effects on that one.
Well, at the time, they thought it was an antidepressant, at least initially. It's not, but they didn't know. So TMS is a class 2 medical device. It has a well-established risk profile, which is not high. Can there be bad things? Yes. But not usually. ECT, serious risks. Drugs, serious risks.
ECT
you could
drugs,
die.
class 3.
Yeah.
So what is it? So what does it have clearance for? What does it have the class 2 approval for?
So the first clearance is for major depressive disorder. You can have monotherapy trials where people are on nothing else, or you can have adjunctive therapy trials where people are on something else at the time. So a great example, this is epilepsy, right? In epilepsy, it is no longer ethical to leave people with epilepsy untreated. So every new epilepsy drug is studied as an adjunctive treatment to only partially effective epilepsy care, which means 0 new epilepsy medications have a monotherapy indication. So they'll all say, Keppra is approved as an adjunctive treatment to standard of care treatment in the management of epilepsy.
And when TMS was going for clearance, we already had SSRIs, and so
Correct.
All of our patients were already on some treatment for depression.
But no!
Okay.
So you would think, right? So they did something when they did that study, which is they took people who hadn't responded to their initial antidepressants, and they took them off of them. So the initial pivotal trial, where Mark George was the PI, was a monotherapy trial. And so they did that and got an FDA clearance for transcranial magnetic stimulation as a monotherapy for patients who are resistant or have not responded to, that's the language, to prior antidepressant treatment.
I mean, the FDA considers this effective.
The FDA considers it safe and effective for whom, with what problem, with what limitations. And this drug labeling or device labeling process is a whole to-do, because to say this is safe for the treatment of major depressive disorder and effective is different from saying this is safe as an adjunctive treatment to standard of care treatment in major depressive disorder, is different from this is safe for major depressive disorder and effective only in those who are not considered refractory to traditional treatment, which is what a version of what the flow label says. So that's a whole negotiation, which is what happens before it's ever gotten to the market for most of these things. Large-scale groups of people have not taken these drugs by the time these labels are in place. And so they're crucial for marketing because the FDA is fundamentally, with that label, regulating what you can market your device for. But then we go use our medical licenses for whatever the heck we want. And it's between us, our patients, our God, and our medical malpractice policies and subsequent lawsuits to determine what could or should have been done. But that FDA label prevents us from getting sued in some awful way if we do something truly off the rails.
So write it down for me in one sentence. TMS was FDA cleared for?
FDA was cleared for major depressive disorder in patients who had not responded to standard of care treatment.
Copy that.
I'm not like reading that off the FDA website. I'm doing it out of my brain. It
Pretty
could be off a little bit.
Yeah.
This is why you have an intro.
And that's right. And okay, so that was the first
That was
FDA,
the first one.
That was the first time the FDA said this is effective for X group.
Correct. And then brain sway using the technology from NIH, got another label on their H coil, which said the same thing, basically. So it said we can treat major depressive disorder with our H coil, not just the figure of 8 coil. And then the Cambrian explosion happened. And then we had for treatment-resistant OCD. And then we had for smoking cessation that hasn't responded to traditional standard of care treatments. And then we had anxious depression. And then we had depression in older adults. And then we had depression in adolescents. And then we had this fancy accelerated version, which is a combination of an AI algorithm and doing it 10 times a day and doing it 5 days in a row and doing it a different pattern, which is SAINT. And then we had SWIFT, which is doing that same H1 treatment in a different pattern 5 times a day over 6 days with subsequent once a week getting 2 treatments over the next 4 weeks in that study.
And is the FDA doing a specific device and protocol for each of these indications? It's not saying just TMS, right?
No. So every new device, the manufacturer has to go to FDA, but they don't have to do a new study anymore. So this is some of the horse trading. BrainSway, the company, as the study sponsor, gets an FDA label on its TMS coil for OCD. And then Neuronetics turns around and says the initial BrainSway approval that they got their clearance, they got their device cleared on was based on our data. Neuronetics did a trial. BrainSway said the H coil is substantially equivalent to our coil. And then they did a study that said that their coil did OCD. And since their coil was the same as our coil is the same as their coil. And so our coil treats OCD. And then, MagVenture makes them, MagStim makes them, Cloud TMS makes them, AMPA all these companies make TMS coils. And they say, hey, look, since our thing is substantially equivalent to their thing, and their thing has the label on this, then we do the thing. They all have to go through this process of going to the FDA and getting an FDA clearance on their substantially equivalent device because there's not meaningful protection on the intellectual property when it comes to TMS, which is why this is such a terrible business for TMS device manufacturers compared to drugs. A drug can make a bazillion dollars because it has very strong patent protection and nobody else can sell your drug for many years. When anyone can sell the thing.
We have to go to break, but I need to make sure I'm understanding your answer to this first. So when these companies with their devices go to the FDA and say, we're substantially equivalent, and we have data that shows is it our device or our protocol?
Our device and our protocol. It's both.
And works in these particular indications for these particular...
And so I'll summarize it.
Yeah.
We have transcranial magnetic stimulation done with high frequency stimulation and with intermittent theta burst stimulation. Both of those patterns have FDA labels from various manufacturers for the treatment of major depressive disorder that's resistant to current standard of care treatment. We also have treatment refractory OCD. Number of manufacturers have it. We also have smoking cessation as label, anxious depression, and then up to 86 down to age 15. And more is coming, but we're not there yet. There's also the tweak that accelerated protocols are approved with 2 different devices. One of them is the SAINT system by Magnus Medical, and the other is the BrainSway Swift protocol, which I was an investigator on.
More is coming indeed. We're going to take a quick break, and when we come back, we're going to talk about common side effects of TMS, how to talk about TMS with patients, as well as what we are thinking about for the future of TMS.
And we hope to understand why it made sense for anybody to go through that regulatory process so many times.
I think for most people who go into psychiatry or therapy, running a business is the last thing they wanted to do. But then we come to find out that for us to have a practice that is thoughtfully built to give our patients enough of our time and expertise, we have to develop our business and organizational skills just to make it work. If you're hoping to simplify the business side of your practice, Simple Practice is the tool for you. Simple Practice is an all-in-one EHR that is HIPAA compliant, high trust certified, and built specifically for therapists. Simple Practice brings scheduling, billing, insurance, and client communication all into one place so that you're not juggling multiple systems throughout the day just to run your practice. Simple Practice makes documentation less daunting and less draining so you have more time and energy to give back to your patients. And if you're just starting out or growing your practice, there's also a credentialing service that takes the headache out of insurance enrollment, which honestly can be a huge lift. Simple Practice is trusted by over 25,000 health and wellness professionals, and you can feel that it is thoughtfully designed for our work as psychiatrists and therapists. If you are ready to simplify the business side of your practice, now is a great time to try Simple Practice. Start with a 7-day free trial and then get 50% off your first 3 months. Just go to simplepractice.com to claim the offer. Again, that's simplepractice.com. As a podcast listener, you know that podcasts are perfect for adult learning. Adults know what they need to learn and they know how they want to learn it. And for me, when it comes to studying for board and licensing exams, there is no substitution for doing multiple choice questions. If you are studying to beat an exam, I think you should use Beat the Boards. Right now, Beat the Boards is offering bootcamp listeners a great deal. You'll get free access to over 4,400 exam-style questions for USMLE Step 2 and over 4,500 questions for USMLE Step 3. Again, this is not a discount code. These exam questions are totally free for bootcamp listeners. I use Beat the Boards to study for my own board exams, as well as several other services similar to this, and I really did find that Beat the Boards was the best by far. Go to beattheboards.com/bootcamp to sign up and get your free questions. That's beattheboards.com/bootcamp. Hey, Bootcamp listeners, I want to talk to you about Cozy Earth because Cozy Earth is ruining my marriage. When my wife or myself slips into a Cozy Earth product, what we find is that we are functionally paralyzed for the rest of the evening, leaving the other person as a single parent for the time being. These products are so comfortable, you can tell that they are obsessively engineered. And I thought that I knew something about socks and comforters and blankets, but until I tried the Cozy Earth version, I realized that I really didn't know anything at all. Cozy Earth stands by their products with a 100-night sleep trial and a 10-year warranty, which is pretty crazy. And if you go to cozyearth.com, you can use my code BOOTCAMP for up to 20% off. If you get a post-purchase survey, be sure to mention that you heard about Cozy Earth right here on Psychiatry Boot Camp. Experience the craft behind the comfort and make every day feel intentional. Welcome back to Psychiatry Boot Camp. So you were saying before the break that these companies, basically the whole way that this system works in terms of the incentives for companies that make these devices, market these devices, and are having to fund these studies, the whole incentive structure is different with regards to FDA approval because they don't have these ongoing intellectual property protections from the FDA like drug companies do. So why are these companies in this space if they stand to make so much less money than if they had taken a different approach like drug companies? And maybe a more direct way to ask this is, you seem to have dedicated a major part of your life to this. Why?
I'm lucky to have been trained in mentalization-based treatment by Peter Fonagy, Anthony Bateman, and others. Mentalization-based treatment teaches you to see the world, not only as you see it, but to imagine what it might be like for somebody else. And so I think a lot about what's in people's minds and their incentives. It's the only psychotherapy modality that helps me think about my colleagues at a payer and why they might do what they do and why they might be more or less interested in what I'm up to. One of the problems with psychiatry is we don't have a lot of procedural stuff. And some of us are work in industry, but most of us don't. When you're a surgeon and you're in the OR, there's a device rep in there like a lot of the time. Like they know the screws better than the surgeon does. And so other medical specialties just have much closer relationships with industry in ways that are both, plausibly pernicious, but can be helpful and collaborative. Like device companies are making devices for surgeons because if they don't, no customer, right? It's got to work for the surgeon. We don't spend as much time with our pharma colleagues, and when we do, they're selling us something. So here we have this range of medical devices that for a quirk of history and a decision of basically one guy to not patent his initial thing meant that it was really hard to make traditional medical device money. We also have a bunch of other stuff about psychiatry that makes it hard to make any money here. Any money, I mean, like investors would consider that a real return if they could also choose Google or Apple or whatever. That's our competition for money, is those companies. Money doesn't care. It wants more. Our patients need treatments. What do we do? And so I decided to try to understand the incentives behind these things. And so I looked at TMS devices, which seemed like basically like generic drugs. Right? We have a real problem with supply chain and generic drugs because it's really hard to make any money there. There are some fixes for that. The Hatch-Waxman Act, which created the generic drug industry as we have it, because we actually pay less for generic drugs in the US than the rest of the world, and vastly more on-label drugs. That's a trade-off we made in a legislative process, and we can feel the way we want to feel about it. We have generic TMS. That's a good way to think about it. TMS is a generic intervention. So all the money in TMS is in the delivery of the TMS itself, which is individual health providers and like you and I, physicians, nurse practitioners, etc. We get paid to deliver this treatment at some amount of money decided by the AMA, or at least some amount of money decided by a calculation made by the AMA to split the baby around the fact that psychiatry has a really low rate card compared to other medical specialties. And yet this is a procedural treatment that requires a bunch of kit. And then insurance payers put a multiplier on that relative value unit calculation, which should be there, but isn't, because TMS is carrier priced at the AMA. And again, it's a whole thing, right? But at the end of the day, all medical procedures have math behind them. It's physician time multiplied by how expensive it is to be that kind of doctor. It's more expensive to be a surgeon than a psychiatrist. Multiplied by the medical malpractice cost. How likely are you to be sued? And psychiatrists don't get sued that much. And multiplied by where you are in the country a little bit. And that's the math behind turning a amount of time you spend into a dollar amount calculation, a relative value unit. And I apologize for my slipping over my words sometimes, but that's going to lead into explaining why I care about this so much. I have tardive dyskinesia, and that's a movement disorder caused by long-term exposure to antipsychotic medicines, which I had to take for many years. And it's caused not only a problem with movements of my mouth, sometimes dystonias of my foot, but I trip over my words now when I didn't used to. And so why do I care so much? Because TMS doesn't hurt people in the same way. I mean, there are risks, and we'll get into it. But oral medications for depression, bipolar disorder specifically, psychotic disorders, come with tremendous risks. Obesity, metabolic syndrome, permanent and disabling movement disorders, which I, as a psychiatrist, have. Our patients die 20 years earlier with severe and persistent mental illness. And from an ethical standpoint, our job is to make the money line up with the outcome we want to see in the world. So if no one's making enough money on healing those patients, why not? And how do we fix it? Because until it's good for money, it's not good for our patients. And it's not good for them if it comes out of their pocket. These are vulnerable individuals, and I am among them. And that's why I care. It's an ethical stance. I want to protect the health and safety of our patients by providing the most effective and safest treatment at the same time. That ratio's got to be right. And I want to feel good about what I'm getting informed consent for. And that means building systems that align incentives. And so I had to look around in the world and find where was that possible. And TMS was a place where that could be possible. Because it's possible to drive down the cost of TMS if we want to. And it's necessary to capture the value if we're especially clever. And it's certainly possible to make that argument to people who care about money, which I unfortunately don't.
Right. And I think that's where it all comes back to us, is it's ethical, but it's also pragmatic, right? You're taking this approach based on how the world actually works, not how...
Yes.
And that's something that doctors are so bad at, right?
We're terrible at. Yeah.
Is thinking about how the world actually works, because we prefer to kind of read a textbook and, think about mechanisms.
But it's not just how the world actually works. It's how the people moving through the world think about themselves. Because there are people who do terrible things with their time, it turns out, who don't think of themselves that way in the moment, right? You can be working at a health insurance company and denying every single claim and tell yourself you're doing a wonderful thing for the world. And you may be for justice, maybe less so, for non-maleficence, possibly, for autonomy, definitely not, right? These ethical principles are in balance. We can't give everything to everybody. We can't give unlimited pizza and unicorns and rainbows to the whole world. That's not real. But if what we want is the best outcomes for the most people that are the safest and most effective, we have to make those arguments effectively. And if we don't, we're abdicating our responsibility to our patients. And I'm not okay with that.
I think the primary point that you drove there was the safety and tolerability of TMS relative to our other interventions for severe and persistent mental illness. So let's get granular again. Can you walk us through the most common side effects of TMS? What are some contraindications to starting TMS treatment?
Contraindications are easy because they're limited. Absolute contraindication. Iron containing metal in the head, like top of your head, not the bottom. Like it's a magnetic field, the field strength falls off rather quickly. So if you have a cochlear implant, you're not getting TMS. If you have an iron containing bullet lodged in your forehead, you're not getting TMS. If a titanium plate in the back of your head, that's probably fine. I've done that before, etc. Facilitatory treatment that increases the rate of firing with epilepsy. Absolute contraindication will give someone a seizure. Relative contraindication, well, we could do inhibitory treatment, which would reduce your risk of seizure and plausibly be a treatment for your epilepsy. Maybe that'd work. Right. So there are a lot of relative contraindications. Risks, the only permanent risk that I worry about quite a bit is tinnitus or ringing in the ears, because that is also a brain circuit disorder. Acoustic injury is part of the plausible mechanism here. I personally suspect there's a brain circuit component to it. But tinnitus is a risk in about 1 out of 1,000 treatments. Seizure is a risk of TMS treatment, but it's actually less likely than oral medications are to cause a seizure. And if that seizure happens, it happens right in front of your face in your office. The scale of this is at worst 1 in 1,000, probably more on the order of 1 in 30,000. And it's about 100 times the rate of that risk with Wellbutrin, and maybe 10 times the rate, depending on the sample you're looking at, for Prozac. But that happens on the street, not in your office. Those numbers are constantly being updated, but it's at worst just as likely to cause a seizure as any of the other medicines we're administering for depression. There's a few more. Commonly, headache, fatigue, scalp pain or tenderness, and that's about it.
One of the things that I'm hoping is that people who listen to this podcast who are not going to be doing the TMS themselves, but who do see patients, will be able to explain this to their patients and understand what their patients are going through when they send them maybe to someone like you for TMS treatment. Can you tell me about what this actually looks like, logistically speaking, how a typical treatment course progresses, what happens to the patient, right? They go to the first appointment and what happens there, and then what does it look like in the room? What does it feel like when this is being administered?
So every psychiatrist should use TMS as one of the treatments they offer if they're treating patients with depression. Pretty soon, that's going to include psychosis and other conditions. I've actually just about to submit a publication on auditory hallucinations. Large phase 3 data. But I think this is a core tool of psychiatry, so it's not if, it's when. Get on board. Now, what do you need to know to either refer to TMS or to do it yourself? But I would encourage learning how to do it yourself. Historically, again, we talked about the development of TMS. Mark George's lab at MUSC was open 5 days a week. So how often was TMS done?
Makes sense.
5 days a week. And how many treatments did they need to do? Well, they had to pick. And they did. They picked a number, and the answer was 36 total treatments. Is that the right number? For some people, it's great. For others, it could be 20. For others, it's 50. For others, it's more. I don't get to know. I know what they did in that first study was 36, and then we did a bunch of that. Subsequently, we have data that 44 is great in some people, blah, 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 blah. Brain Sway showed efficacy at 20 stimulations. But what's going to happen is they're going to come into the office, and you're going to put that magnetic coil on their head, but you're not going to put it where you're treating them first. You're going to put it over the motor cortex.
When you say put it on their head, are you setting a metal object on their head? Are you holding it over their head?
Just like these headphones are on my head, and you have a
You're
band
setting it on their head.
You're setting it on their head,
Uh-huh.
and you're moving it around, and you're either eliciting a movement from the thumb or the foot if you're using the OCD coil. But it's like a reflex hammer. You tap it, fire, did the thumb move, yes or no? And then you get the thumb to move, and you're moving it around, and you want to find the peak area where you make the thumb move the most with the same amount of energy.
You generally know where that's going to be, but for each person, it's a little different. I mean, well, it's not going to be in the back of your head for some and the forehead for others.
No, it's in the motor cortex.
Right. You know, generally, you have to feel that out.
Yeah. So you're finding where the hot spot is in the motor cortex, where you get the most movement for the same amount of energy. And then you find the motor threshold, which is defined as moving half the time. What's the energy at which you move half the time? There's actually some complicated math you can do around, like, you go up to 37, you go down to 33, it moved or it didn't, and you're doing this yes, no algorithm, or you can just do 1, 2, 3, 4, 5, 6 pulses, and did it move half the time? And then you go down, and then you go down, and then you go down. And then when it stops moving half the time, only moves once, now you're below the motor threshold, it was 1 up, right? So you're moving a thing around to find the spot, doing a bunch of pulses in that spot, and now you know the energy to deliver. That's called brain mapping and motor threshold determination. The brain mapping spot does not change. So if you mark it down in your electronic health record or in your machine, you can always go back to that same spot and elicit the motor threshold again. However, the motor threshold does change, and I'm here to tell you it actually changes daily for some people. So when we developed this treatment, we measured once at the beginning and once a week thereafter. In my entire career of clinical practice, I've measured every single day, sometimes multiple times a day, and it changes.
That's fascinating.
And so it turns out like the dosage originally when Dr. George was treating individuals with this, he started at 100% of motor threshold, and that worked a lot, but not all the time. So he turned that number up to 120%, and lo and behold, it worked more often, usually in older individuals. Now we know their brains are somewhat further away, so we need more energy to get to the surface of the cortex, because this is magnetism that follows in our squared law. I know you hated physics, but we're still algebra. We're not calculus.
No comment.
It's further away, it gets weak. So there's, again, some math around what the percentage is of the power that you do, but your doctor is going to make the decision. Theta burst is more potent than high-frequency stimulation, so we can use a lower percentage of motor threshold, but it might be more uncomfortable at first. So generally what happens is we find the spot, and then we're finding the energy, and then we're using a percentage of that energy, but in the beginning it's less tolerable than it becomes, because the brain is actually gradually editing out how nociceptive, how painful it is. And so we started a low power, and we go up slowly. And that's within a train for some individuals, or between them depending on the device. But stimulate the brain with a pattern of stimulation, pause. And there's an intersession interval. That's either 24 hours if you're doing it once a day, which, by the way, is kind of a waste of your time. Don't bother. I'm an acceleration maxi. Or you're doing it multiple times in a day at an intersession interval.
Which is less frequently done in clinical practice at this particular juncture, though. Is that right?
Yes, less frequently done, but it's not uncommon. And we now have 2 FDA-labeled versions of the treatment with 78 and 79% remission rates. So get on board, people.
Yeah, you're excited about this because it's coming, but your average person...
It's here.
It's here. But your average person going to get TMS might wind up with someone... Okay, just to be clear.
Yeah.
Okay.
Because there's a medically unlikely edit on the code set. Because back in 2008, it was assumed it would only ever be done once in a day. And it was as unlikely as surgery on your right knee twice in the same day that it would happen twice in the same day. And that is only recently changing. But that's what's in the way.
Okay, so then so a patient will come in. This is an outpatient procedure. Typically, it's every day. Lately, it's more than once a day.
Historically, it's been an outpatient procedure, but why?
I guess people like to sleep in their own bed. I mean...
No, it's about money.
Well, of course it's about money.
Mark.
Yeah.
Dr. Mullen, how is psychiatry inpatient paid for?
Insurance reimbursement, generally.
Yeah, 2 different ways, though. How is regular medical care? You're admitted to the hospital for something that's not psych. How do they get paid?
In a bundle, typically.
Correct, right. It's called a diagnostic reference group, and you're paid a multiplier based on the DRG. So if you get admitted for pneumonia, you get a chunk of money. You get admitted for heart failure, you get more. Why are you paid more for heart failure? Because we know we might have to implant a device, and that's baked into the cost. Psychiatry historically has been paid on a completely different fee schedule, which is per diem or per day. And there's no more money for you if you have depression or psychosis or anything, because we're not going to do anything different. We're going to have some nurses watch you, a doctor maybe chats with you, we give you a pill, and maybe we change the dose of the pill. No technology there. There's nothing special. Nothing costs more. It's all the same. So we pay the same. Do you ever wonder why we don't start LAIs in the hospital?
Tell me.
You don't get paid more. So we wait till you're an outpatient. So then it's under the pharmacy benefit, not the inpatient behavioral health benefit. But we
God,
can
that's
do it
fascinating.
we can do it with Haldol because Haldol is generic, and we can't do it with Concerta because it's not. Blah blah blah.
For the record, we do that where I work all the time.
Yeah, well, you should, right? But I bet you do it with off-label drugs. I bet you don't do it with.
No. Well, I don't know how all of it works, but we have some pretty good drugs that we give.
Got a rebate.
I think our readmission risk is just so high that we have to do it inpatient because it will never happen outpatient.
But then there's all other reasons that might be the case. So in general medicine, we have what's called the New Technology Add-on Payment Program. So in the ICU, you get admitted for a bundle, right? But sometimes you can make more money on that bundle because you use something new and better. And so when a new and better thing comes to market, you can apply to be part of this new technology add-on payment program, which means there's some negotiated discount. And instead of it costing 100% of the price, it costs 60% of the price, and Medicare covers it for the first 3 years. And then it just gets baked into the bundle. But biventricular pacemakers, ECMO, every cool thing in medicine came through that pathway since 2000.
Let's talk about TMS, though, because I'm afraid
that's why it's not inpatient.
Right. Okay. Sure.
Because you can't get it paid for. There's a way to get paid for ECT, and there's not for TMS until recently, and that's why nobody has it. So it is an outpatient procedure. We do map the brain, we do measure the motor threshold, and then we administer a train of treatments, stimulations. And that's it. Pattern stimulation of the brain, and then you wait either an hour or a day.
Depending on the protocol.
And maybe you get 10 in one day or you get 1 a day, but you get enough stimulation over time and your depression's over. More often than not. When I say more often than not, randomized controlled trial, 79% remission with accelerated protocols. It's about 30% in traditional figure 8 coil TMS in populations who have a remission rate of around 5% with oral medications.
That's pretty impressive, especially for a therapy that is so well tolerated. Although I will maintain, and obviously this is not a problem that you are liking to talk about, but it's not very accessible for people right now, which is why you're doing what you're doing, right? That's your whole point. That's why you're like, we need to spend time talking about incentives but for our people who are just clinicians who are not, they may not be able to access these accelerated protocols right now.
Do you have any idea how cheap it is to go get a TMS machine?
No.
The cheapest one that I know of is like $3,000 a month. Lease, not even lease, a month-to-month contract. So can you find a way to break even when the whole thing costs you $3,000-ish in a month?
I guess I don't know the reimbursement rate.
Do you even care?
Not really.
Yeah, at that price, because you can treat everyone you want as much as you want in a month for $3,000. Let's say you treat 100 people. Boy, that's $30 a person? Like, you can find a way to make that work. That's probably less than their copay.
Yeah.
Or what do you get paid for a 99215 visit, right? It's more than that. They can just come in. I'm not saying, but that's what I'm saying is it's so cheap that the marginal cost of administering TMS is so low that we really should be doing it more broadly. And if we are anchored to the existing reimbursement models, we accept the reality of we can only get paid the way we imagine and not that we can go change it, then we're stuck.
Let's leave our systems level thinking for now. Let's go back
TMS
to...
forces you to think about the reality.
Fair.
The reality is TMS works. You should do it. And if you don't do it yet, go with your patient. Have the TMS doctor show you how they do it so you can learn.
This is why I invited you on the podcast.
And I've done that, by the way. I had my dear friend David Hirsch come down from... He sent me a patient to New York. I treated the kid, but he lives in Chicago. He's not going to keep coming to New York if he needs it again. The dad bought a device for his son to sit in the doctor's office. The son kept getting the treatment. He's doing great. David comes to New York for his next patient. I show him how to do it. He's treating tons of people in Chicago now.
I think you're going to get a lot of phone calls after this episode releases.
This is what I'm here for.
Back to clinical indications. So let's think about... I want you to think about what you, Owen Muir, would consider to be the current standard of care Where are you thinking about TMS in your treatment algorithm? Are you thinking about it as an adjunctive treatment, as a treatment alone? Are you thinking about it in strictly treatment-resistant patients? Where does it fit into your algorithm? How are you thinking about that?
So I also live in the real world, right?
Happy to hear that.
And so part of what I've done is at Radial, we have shaped our practice around what is reimbursed now, not just what we hope to be reimbursed in the future. And so we focus on patients who are treatment refractory and sick. Now, that having been said, I don't actually believe that oral medications, SSRIs, should be used at all. They should not be first-line treatments. We don't have the data to support TMS as a first-line treatment, so I can't say I believe in that. I can say psychotherapy exists, and that's a great first-line treatment. We should probably use that as the first-line treatment, and TMS should be adjunctive to that. Now, in adolescents, that's not true. In adolescents, TMS is approved as a first-line adjunctive treatment, but adjunctive to standard of care, which might be just a nice visit with a psychiatrist who cares about you. Because don't underscore or underrate the therapeutic nature of caring about somebody. That having been said, someone comes to you and they haven't responded to the prior thing. And in our practice, we just say, we don't do drugs. That's not our thing. We'll manage your medications if you're getting neuromodulation with us, but not if you're just here for meds. We're not interested in just meds.
This is why this is kind of an interesting question, is that this is what you do, right? So when a patient comes to you, they want this and you think they're right for it, likely. It's a self-selecting population in that way.
So yes and no. I've also done a lot to change what exists in the world. Like, people aren't jumping up and down to get drugs.
Right. Facts.
Right? They are, I've prescribed a lot of drugs in my life. I've taken a lot of drugs in my life. I'd rather not, and so would patients.
Sure.
So we do have to decide to collect the evidence to support what we think is true. But in good faith, can I either get paid or represent this as an appropriate first-line treatment? I cannot. We have not studied it.
Just because the data is not there yet, for the reasons that we've been talking about this hour.
And when somebody asks me what's true, I can't tell them things that I wish were true.
Fair.
But to be really clear, you're a general practitioner. Someone comes to you with a problem. Let's just assume they're an adult. What's the first thing you're going to do for depression? Therapy. Let's say that doesn't work. How long of a drug trial are you going to give it? And my answer would be until it's demonstrably effective and they're in remission. And at that point, what do you do next? And here's where we have great data. Ascertain TRD was completed last year. It's a really nice study. And they compared switch of oral antidepressants to augmentation with aripiprazole to adjunctive TMS.
Are you saying for patients who are partial responders?
They did not respond meaningfully. They're still depressed.
They did not get into remission.
Correct. Not remission.
Okay.
These are people with depression that's bad enough to get in a clinical trial. Maybe they got some benefit. I don't know.
Okay. But whatever it was remission. So they
not
move on to the next
enough,
step.
Right.
Yep.
All right. And so part of this is we've satisfied ourselves in psychiatry with response as good enough. And that can also go choke on it. It's not good enough. If your depression isn't over, we're not done.
Yeah.
There's no amount of cancer doctors well, great news. You have half as much cancer.
Yeah.
We're done here.
And in this trial, what they found was TMS blew everything else out of the water. Best treatment we had compared to switch and compared to augmentation. Augmentation was better than switch alone, but TMS was better than the other two. And what protocol was that?
That was just standard once-a-day treatment, 20 stimulations, rather low-dose TMS. Because again, we designed studies years and years before they're concluded. And so at the time, they're like, let's just do 20 treatments. And it was 5 or 6 or whatever years ago.
I think you answered the question that I asked, which is, what is your standard of care protocol for the treatment of major depressive disorder? At least that's the question that I meant to ask. I think we can agree that based on current clinical guidelines, your standard of care is pretty cutting edge, and you absolutely would die on this hill and stand by it. I
raised $50 million, which is the most any mental health company has ever raised based on the thesis that this is the right care. And the data has gotten better and better and better. And in kids, it is now a first-line recommendation.
Great. So, you're excited about all of this. What are you most excited about in the field of TMS over the next 10 years?
The thing I'm most excited about is the fact that we have a safe and effective treatment that can be deployed rapidly and get people reliably to remission. And dun dun dun, not in definitive studies yet, but with early open label evidence. We have an open label clinical trial by Jonathan Downer and company called the 1D trial, which demonstrated you could do D-cycloserine, an ancient tuberculosis drug, augmented transcranial magnetic stimulation, and you could do 20 stimulations in one day, and it worked.
Why?
Why? Well, it turns out D-cycloserine potentiates neuroplasticity, and that allowed it to work. And just today, a preprint came out on a propensity matching study, which is some, study design not usually used in psychiatry, actually used quite often in cardiology and other fields of medicine. But we're looking at patients matched by a series of factors, and we compared this one day TMS to once a day TMS, and it was better. So now we have to do a pivotal trial with good randomization and good controls. And so one of the innovations recently in the SWIFT trial, which I participated in with the Brainsway as a study sponsor, is it was comparing two active treatments. We randomized people to once a day TMS and treatment-resistant depression, or 5 times a day treatment-resistant depression over 6 days with some taper. And that was important because what we learned in the SAINT trial that Nolan Williams designed was that if you do a powerful enough thing compared to sham, at the midpoint of the study, the IRB will shut it down because it's unethical to continue to give human subjects sham when you know it's definitely better. And so we can design the SWIFT trial to minimize the risk of that early discontinuation because everyone was getting active treatment. My favorite story about being an investigator in that trial is one of the patients was too sick for the study. She was too suicidal to get into the trial. So what did I do? I gave her off-label TMS clinically.
Yeah.
Because she was going to die without it.
Right.
Can't be in the study, but definitely needs the treatment, because it was already FDA labeled for people with depression. So what I'm most excited about is one-day TMS. And the reason I'm so excited is that the device that company AMPA made, again, conflict of interest here, I'm an advisor to that company, but they made a light and cheap device that can go to the home, fits in your luggage on a carry-on. I've flown with it.
And do a treatment in one day.
In one day.
Yeah, it's
Put
pretty
it in the
amazing.
trunk of your Camry,
It's pretty amazing.
roll up to someone's house. It's got a camera in the coil so the tech can get it on the right spot without screwing it up. It's a design solution to the problem of not enough TMS.
To state the obvious, it sounds far too good to be true. So I'm very excited as well to see what comes of this.
And so the good news is we don't have to believe that it might be good. We have to prove that it will be. Now, you first have to design a thing that's technically possible. It's actually similar to psychotherapy, right? Psychotherapy sounds crazy. You're going to talk to someone and they're going to not kill themselves. Yeah, but you have to talk to them a couple times and you have to have read a book first, right? And we have DBT, we have schema therapy, we have mentalization-based treatment. We have the most effective treatments on earth are psychotherapies for suicidal people. But you have to design the manual first. It has to be possible. You have to know it's possible. You have to know it's reliably replicable. TMS is the same. You have to have a device that can get to the patient, that can be reliably placed on their head and deliver the treatment you think, and only then can you study whether it works.
In order to prove it, you're not saying that you need manuals to have psychotherapy. You're saying that you need manuals in order to prove that you're doing something reliably and that it has the effect that you think it has.
Exactly. Manualization isn't necessary for effect. It's necessary to demonstrate what you thought did it is what did it.
Owen, we got to wrap, but I know you're going to want to say a couple minutes more on what you're most excited about. Is there anything else you need to get out before we wrap?
That was just TMS.
No, Believe me, as a reader of the Frontier Psychiatrist newsletter, I know. Any final thoughts for our audience?
Yeah. You have tremendous power to heal your patients, and it doesn't take TMS to do that. It doesn't take drugs to do that. It takes your curiosity, your compassion, your interest in them and their life, and that is enough. In fact, it's the most powerful part of anything we're doing. The placebo effect is the effect that we're trying to build on with science, but science only incrementally builds on the power of hope and the ability to sit there and really feel what someone is feeling, tolerate it with them, and stick with patients who are suffering is the superpower we have. My favorite patients are not those who respond well to TMS. They're the ones who don't and who I have to stick with, because if I don't, they're going to lose hope. And so our ability to carry hope together with our patients when it's too heavy for them alone, that's what makes a doctor. It's not the technology. It's not the science. I do the science because I want to be able to offer hope on top of that. I do the math so I can figure out what makes sense to my colleagues at payers and investment funds and all that stuff. I don't care a lick about it. I care that I can stand there and say, let's give one more thing a try. I just read this paper by a colleague and maybe it's worth it for you. And even if it doesn't work, I'm here with you. One of my greatest joys, I have to say, I work with a lot of patients who've been in clinical trials and it hasn't helped them. And they're coming to me for what next? And when you're sitting there with somebody who was a participant in a brain surgery study and it didn't help, and they're asking you, yeah, but what can you do? That's a moment I cherish, because that person's contributed to our field with their life. I'm one of them. Like, I had J. John Mann sticking a needle into my spine to measure serotonin precursors when I was 20 years old. Became a psychiatrist because of it. I respect the heck out of that. And I also think what was powerful about that study wasn't that it helped me. It was diagnostic. But I became a doctor because of my experience of someone just being curious, not even promising to do anything. What we do is profoundly human. And if we lose that and think it's all science, we lose the threat.
That's good. This is a really important note to end this particular episode on a technology that I have not pretended to understand at a terribly high level. And I think it's tempting to look at a technology like this, or to, let's say, accuse a prophet like you of this technology, of saying this person is trying to sell this technology and say that it's going to solve all these problems and leaving the humanism behind. And I really appreciate you giving us that disclaimer that says that is not at all what you're trying to do. You're excited about this because you've seen the data and you've seen the people that it's helped, but bringing us down to the soul of psychiatry, I think is super, super important.
1 million people a year are being treated in China with TMS every year. Here we treat 100,000. We got the incentives wrong. But it's a problem of ethics and soul, not just practicality.
Thanks for coming on the podcast, Dr. Muir. I've really appreciated it. Thank you so much for listening. If you're enjoying the show, I'd love to know what you think. You can connect with us on TikTok or Instagram at Psych Boot Camp, or you can email me, mark@psychiatrybootcamp.com. You can visit psychiatrybootcamp.com to sign up for our newsletter. You can connect with the rest of the Human Content Podcast family on Instagram and TikTok at Human Content Pods. Thank you to everyone who has taken the time to leave a rating and a review. If you want to support the show, the best way you can support the show is by writing a review on Apple Podcasts or leaving a review on Spotify. We're going to feature some of those reviews in upcoming episodes. We're also on YouTube in addition to Apple Podcasts and Spotify now. Find us on YouTube at Psychiatry Boot Camp. Thanks again for listening. I'm your host, Mark Mullen. Our executive producers are Aaron Corney, Rob Goldman, Shanti Brook, and me, Mark Mullen. Season 4 is produced by Matthew Braddock, and this episode was outlined by one of my graduating M4s that I am so sad to see go, Porva Chef. Our editor and engineer is Jason Portizo. Theme music was generously donated by Cave Radio. Find them on Spotify, and additional music by Omer Ben-Zvi. To learn about our program disclaimer and ethics policy, our submission verification and licensing terms, as well as our HIPAA release terms, go to psychiatrybootcamp.com, where you can reach us with any questions or concerns as well. Psychiatry Boot Camp is a Human Content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.